Okay, wonderful. So we have about 15 minutes for some nice panel discussion. And I want all of you to get very engaged here. So I think first thing we want to talk about is patient selection. I think it's the recurrent theme. We just heard John Forrest talk about these silent lesions. We know that all patients have diffusion-weighted MRI, ischemic injury of the brain. We're treating more and more, younger patients, lower risk patients. So I guess question number one is, should this be selective? Should we be treating all patients? And that's not the reality right now. And then how are we thinking about our young patients? Do we think that they're a higher risk? Is it more important to treat the younger patients? So, Tameen, I'm going to start with you. We're going to go down and get the opinion.
It's a very challenging question. The issue, and I think Dr. Moses showed some of the predictors of stroke. We don't have great predictors. So the idea that you can somehow select the patients that are going to have this relatively low frequency but potentially devastating complication may not be clinical reality. There are some patients, if you're doing a degenerated bioprosthetic valve-in-valve or something that is clearly high risk that you're certainly going to do, but we've adopted a position of protecting all patients using sort of the seatbelt analogy. It's an unpredictable event. We therefore give the patients the benefit of the doubt. And if you discuss it with the patients, they universally want it done. If you talk about the doctors and ask, why aren't you doing it? It seems to only be a financial barrier, best I can tell.
I think the young versus the older patients is an interesting thing. Certainly, we want to prevent it in young patients. It makes great sense. On the flip side of that, it's quite possible, and the data would suggest that an older patient may have a small lesion that actually causes overt problems, whereas the young patient would tolerate it. So saying you're not going to use it in a young patient or in an older patient just for that reason doesn't, I think, make a great deal of
brain
sense.
elasticity,
Exactly.
So ability to recover. Yeah. Okay, Raul?
I think this is something that's really important because we're seeing obviously an indication creep and a paradigm shift in terms of the treatment. But for me, at the moment we're treating all of our commercial patients, at Cedars. But for me, I think now that the devices have advanced to the point, particularly with the TriGuard 3, where you're not interacting with the great vessels, and it is so easy to use, keeping in mind that most of the data does apply to an older risk population, I think that while brain elasticity for sure is going to be a positive prognostic factor in younger patients, the consequences of a stroke arguably in a younger patient in terms of health economics and contribution to society and quality of life years is far greater than perhaps, in an elderly patient population. So in my mind, I think now that the devices are very safe and easy to use and will only get better, I would err towards that seatbelt analogy of treating all patients.
Right. So, Peter, are patients asking for this?
Yeah. So, thank you for not letting me echo the opinion of all the others. No, certainly. So coming back to your first question, I think Jeff showed the data that there's no predictive model. So basically, I think you should need to use it in all patients. And we indeed have the situation in the Netherlands that there are just a couple of centers using cerebral protection in the Netherlands. And we get patients from around the country coming to us because they know we are using and taking care of this aspect. Yep.
So I think at this point, with one device which is commercially available for embolic protection in towers, every patient should be evaluated for at least and should be offered an option of embolic protection.
Yep.
At our institution, we're considering embolic protection for pretty much every patient, and depending on how the patient wants to be pursued and how we think that the patient should be treated, accordingly we either fit them in a trial or treat them commercially. I don't think at this point there is any one single predictor that will predict strokes in any patients, no matter younger versus older. And in my opinion, any stroke is a stroke, small or large, it doesn't really matter. That's my 2 cents.
There
I
he
think
is.
that we are going with innovative techniques to replace the old ones. So TAVI is by itself as a direct comparison to surgical valve implantation. So we should go with the better method. So I think when the device is easy to use, with low risk of complications, like looks like, and with the good protection, I think that it should be in near future the standard of care for any kind of TAVI. We are going, as I said, to simplify TAVI, so we go quite fast with easy puncture, with local anesthesia, not so complicated. So adding just this quite easy device to really protect brain, I think that should be a standard of care even in near future.
Nothing really sensibly to add. Okay, one is we have no predictors for stroke, so I think there is no reason to select patients. A difference between elderly and younger patients, I think definitely no. It's devastating for everybody. The key issue, at least in Germany, is to get reimbursement for that. If we don't get reimbursement for that, the penetration rate will, now it's about 5%. It will not increase significantly.
Right. So I think, given the numbers, I mean, in the US, it's a different scenario than in Europe. I think you've had these devices available to you for longer, and still the penetration is low. So we'll come back to reimbursement in a while. So if there are any questions from the audience, please step up their microphones. We're happy to make this very interactive. So let's go on to device selection. So Tamim, you talked about you showed a case, Mike showed a case. It looks very easy, 3 minutes. I'm going to put you on the spot. Can you compare this device? I don't know if you used the first generation device. I know you've used the Sentinel. Can you help us put this in context?
Yeah, so I would say if you're thinking in generalities, the optimal device that you could imagine would be a device that fit into the TAVR procedure with the most minimal disruption possible, and that provided complete 3-vessel protection. I think those would be the sort of 2 most important things that would jump out. It's an accessory device. You don't want this to be the focus of the procedure. You want to be performing a TAVR. The TriGuard HDH device was harder to see, and it was clearly less stable. It also required you to interact with the innominate. So I think the TriGuard 3 now is much easier than the HDH. Clearly, it is quite stable, and it's through the femoral access, which is just an easier way to work in a TAVR procedure. The routine TAVR procedure is bilateral femoral access. Can you get radial? Sure. It can be challenging in these older patients, especially with tortuosity and other things. But it's just another access point that we don't typically get in the procedure. So it is easy for me to work through the femoral vessel.
Yeah, okay. So Dr. Doble, you're the highest enroller, as I understand, for REFLECT. So can you talk about the stability of the device? The first generation, I have to say, there was, attention. We had to pay attention to the device and reposition it. Right. So how about this one?
So having used both devices, the HDH one and the TriGuard 3, there is a day and night of difference. The first generation device, the HDH device, was anchored into the innominate artery, was less stable, and plus the stabilizing arch that was there, there were a lot of manipulations that were needed to just cross through that. So the procedure was more focused on embolic protection than the TAVI itself. On the contrary, this procedure, the new device, has made it so simple that in my experience, it adds about 3 to 5 extra minutes to the total procedural time. Not much manipulations are needed for any kind of transactions through the arch. And the device is very stable unless the valve itself physically interacts or gets hung up onto the device.
Okay. Any comments on there's some device umbrella in particular that hasn't gone forward because the positioning actually was linked with more cerebral embolization? Between the devices, Sentinel and this one, I mean, this one seems like it deploys, it self-positions. There's very little positioning that goes on. Any comments on that?
So as Tamim pointed out, you need an extra access for Sentinel device. And then ergonomically, sometimes it may be not as, operator friendly, the whole situation. So we like to have device that is done through the femoral access, because we get femoral access for the pigtail catheter anyway. And by reducing the size from 9 to 8 French for this new generation TriGuard, it has made it even simpler than the first generation. So I would say if this device shows any kind of promise in the clinical trial, I think this will be the device to go, just because it's done through the femoral artery and has the entire arch protection.
Okay. The distinction between capture and deflection, Raul, maybe I'll give this one to you. I mean, you look at all these CTs, you've seen the extent of calcification and disease.
Yeah, I mean, just a comment just on the previous issue as well. I think, having looked at all these CTs, for me, the biggest improvement or advance or positive factor of the newest TriGuard device compared to the older generation, or in fact compared to Sentinel, which, as I said, we put in every day, is the fact that you're not interacting with the inominate at all. And I'm always concerned, having looked at all these CTs and seen how much tortuosity and disease there is and how much calcification there is that we don't appreciate angiographically, I'm always concerned about manipulating anything through there. So for me, the greatest advance has been the fact that we no longer have to involve the inominate. I think the issue of capture versus deflection, at least the data has not borne out that deflection carries with it any significant, clinical adverse events. Theoretically, of course, there's a risk that these embolize, to watershed areas and organs, but, at least that in the data that hasn't been borne out, and certainly in our clinical experience, we've had no issues with distal embolization. I think, the idea of capturing seems intuitively like a better idea, but I think, at what cost, and that comes in terms of, having two baskets inside two greater vessels. I'm not sure it's worth the cost of interacting with those great vessels.
John?
I agree. I think the great benefit of capture is that it allows us to know what the debris is. I don't think that there's much more benefit than that. I mean, we know that there's a lot of blood that goes up to the brain, but it's not the majority of it. And, I can recall one case in 1,000 that we've done where it seemed like there was some distal emboli in a digit, but it's a very rare thing. And you're not, if you're trapping less than 40% of the blood that goes up to the brain, you're not going to make a significant difference in what you're doing here. It's not like we're talking about putting filters in the distal aorta or the distal arch to try to catch extra debris from going down to the legs.
Right, and we haven't seen, in all these studies, we really haven't seen any differences in renal function or any other complications. Okay, I think, how about the concept of 3-vessel complete coverage as opposed to two-vessel coverage? Dr. Schofer.
I think it's an important issue. When we look at the Sentinel data, there is a signal of a worse outcome in patients who have this unprotected posterior circulation. So I think if you decide for protection, you should protect the whole brain, of course. May I ask a question to Michael Mack? He's a surgeon. Michael, do you see any rule of this protection device in surgical cases?
Mike, come on up here. Let's see.
So the answer is yes. I think the risk is just as great in surgery as it is in TAVR. We did do a embolic protection trial with 2 different devices in surgery, both of which were unfortunately negative. We have actually extensively discussed modifying this device for a surgical application. There are a number of issues with it, including interaction of the device with the aortic cannula, with the aortic cross clamp, and we distort the aorta with that. The company we've sent a number of CT scans of patients that have undergone surgery to the company, and we're working on seeing if we can modify this device to use in surgery.
Okay, thank you.
Peter.
If I can add on that, I think I understand now the current inclusion-exclusion criteria on the study, so we go for just transfemoral procedures. But I think, and that was the experience with the previous device as well, that even if you go to non-transfemoral procedures, it works perfectly. So transapical, but even direct aortic, as long as you make sure that the surgeon doesn't, coming too high, but really close to the aortic valve, as close as possible, 5 centimeters, it's still feasible to use it.
Right. So just a few comments maybe about reimbursement. So
one of the things that I will challenge is I don't think this procedure takes just 2 minutes. And
Okay.
one of the people who are going to
good. It's good to get the
some
sound
of the
of
people who will pay attention to this is CMS and the people who reimburse us. And I'm challenged as to why we haven't taken some lessons from our colleagues in dermatology or in orthopedic surgery who have said if you want to do things right, it takes a little bit of time. If you want to do this right, you come LAO, you take an arch shot, you have to exchange out a sheath, you have to put a pigtail catheter up there. And if you do that slowly and you're training somebody, it may take 15 or it may take 20 minutes. If CMS says, okay, here's something that's of benefit, but it's taking you extra time, they're willing to reimburse you because you're spending your time doing this. So I would just warn our colleagues that if we say it doesn't take any extra time, it doesn't add anything to the procedure, getting reimbursed for it is a little bit more difficult. And having done these procedures and taught fellows how to do it, it does take a little bit more time. It's not just 2 minutes. So when we talk about these things, I think one of the ways that we will prevent ourselves from having so many cuts is to say, we can now do the TAVR in 15 minutes and the patient can leave the hospital in 4 hours, et cetera. That's going to drive down a reimbursement.
So the question is, with the add-on reimbursement, maybe Michael, you can answer this question. Is it going to really move the needle in terms of what's happening in the U.S.? So we're going to see more protected procedures?
So I think so. I mean, CMS has a new technology add-on payment that does allow, Sentinel has just received that, and that has somewhat attenuated the pain of the additional cost associated with this. I think, CMS appropriately is doing that to allow adoption of new technology. And I think it's going to be very, very effective because once you start doing it, you're pressured to say, well, why am I not doing this? Or why am I doing this in some patients and not other patients? So, yeah, I think the additional financial reimbursement that's in place will drive market adoption and universal use. I mean, Raul, you protect everybody at Cedars, right?
Yep, absolutely. Yeah.
We do at Columbia as well. Every case, unless there's an active exclusion, we routinely use.
And how about in Europe? What's the impact of maybe Peter or Darius?
So I think, as I said, that this should be going towards the standard of care for me. So, for example, in our lab, in our CAD lab hybrid room, we use in the past the Claret or more difficult devices, and we're a little against. But if I see that device is simple and really protecting, that will be very helpful. And as I said, in many European countries, we need the health technology assessment report. So it will be the balance between the cause of complication and the cost of the device, and it should be judged. If it's appropriate indicator, so it is easier. And certainly when we see adoption in US better and better, so it will be easier also in Europe.
Okay.
Well, reimbursement in the Netherlands is quite a difficult subject, which we could talk about for the next 2 hours. But I think on a local basis, with my own hospital board, what I've convinced them in the past is that if we can protect on 100 TAVIs, we can protect 2 or 3 stroke patients. That's already enormous cost savings. Right. So that's preventing this is worthwhile paying for it. The second thing is, because we are a very competitive small country in the Netherlands, we have 18 TAVR centers around us. We want to get patients. So the second thing is, if you're able to show that because of this device and you handle it well and you have less complications, you are getting more patients referred, they were all for it. So it's my local solution.
Yeah. Okay. Mike?
So the other thing I would say is that just in terms of invasiveness, surgery is at a disadvantage from TAVR. And the way that I have advocated for cerebroembolic protection trials and surgery is the way this world is going, everybody's going to be protected. In TAVR, now surgery is at an even further disadvantage. You can have TAVR and have your brain protected, or you can have surgery and not have it protected. So,
Good point. You've always been a great argumentalist, making good points. Okay, we've got a couple minutes. I just wanted to finish on this last point. What is the next need? So we've addressed TAVR. I think we're talking about SAVR. I'm including that. Beyond that, what would be the next big need?
atrial fibrillation ablation.
Okay.
I agree. Atrial fibrillation in the EP domain in interventional cardiology is probably going to be mitral interventions. Some of those procedures, especially the valves and valve and MAC, et cetera, I think are going to be high embolic potential procedures.
John?
There are a number of procedures. I think you can sort of selectively do it, but there are even peripheral procedures and other ones where you have a lot of thrombus. You're doing other things where you may want to use it. I think for those it may be used on a little bit more of a selective basis, but it's there, and it's not just limited to TAVR procedures.
Raul?
No, I agree. Ablation and mitral space.
Yeah, I would say all structural heart probably, and atrial fibrillation.
Okay.
I think beyond TAVR is Pandora's box. You can use it for any left-sided structural procedure, even high-risk PCI with a lot of calcium. But I think the next one to tackle would be AFib ablations.
I think there are many interventions when we have some thrombi in the heart and we are afraid of those interventions. When we have the real guards and protections, it will be zero stroke. So we can go to new fields when we nowadays see as a contraindication.
I agree.
It's been said. All right. Well, I want to thank all the panelists, the speakers, Keystone for a very nice session. Thank you very much. And we're done.